Dear students, good morning. Today we have the lecture in the course of endocrinology for dental students specialized in stomatology or dentistry. And I have started the recording of the lecture while I'm still waiting for the students to gather. Hello, Vijan Bedaush. Do you hear me clearly? Is everything okay with the sound? Hello? Do you hear me now? Okay, let me check again. Dear students, do you hear me? Hello? Okay, let me check. I have checked before. Everything was okay. Let me check by other gadget. Yeah, I hear. Do you hear me now? Dear students, are you there?
Hello, doctor.
Hello, thank you for your response. So I hope everything is okay, right?
Yes, doctor, but I don't know if you know that we have another class at the same time.
No, it's a pity. No, I didn't know this.
Yeah,
Okay,
doctor, we have another class
okay.
without you.
So anyway, I will record this lecture for you, make it available. Maybe I'll edit a recording to this invitation. Do you see it on the screen now? Endocrinology and etc. Here is the registration form. And after I finish delivering the lecture, I'll upload the recording of this lecture to my YouTube channel and send the link in this invitation, okay?
Can you
You
repeat, please? Just the answer to the registration form. That's all.
could you repeat, please?
We just only answer to registration form.
I understand that you are busy now. Here is the registration form, of course. Follow it and let me see if your um, registration is okay. Yes, please. Yes. Okay, so today is 28th, right? 28, diabetes mellitus. Now I'll see if you have registered or not. At the moment, no one has registered. Just exactly when anyone would register, I'll see the registration date. And could you please tell what subject do you have? What studies do you have at the moment? In what subject or in whatever?
It's orthodontic.
Orthodontic. It's very strange because I checked several times cool. that now you have, by according to your timetable, now you have the lecture in the endocrinology. And you have practice in orthodontics, right?
Yes,
Hmm, very
with teacher
strange.
Tatiana.
Okay, thank you. Thank you anyway for your response. I hope this will be okay anyway. I'll deliver the lecture for you. You'll get the link to this recording. And you already, for instance, you already have the access to presentation, if you see. Okay?
Yes.
Okay,
Yes, I
so
see it.
okay, good. For maybe I'll get some extra materials for you on my blog. But don't forget to register, okay? Here at the
Yes,
moment
I
there is
will.
no one in the registration.
Because all of them they joined to the class.
Okay. I understand, but just
Okay,
don't forget. Don't forget.
okay, I
Thank you
will.
for coming. So good luck. See
Okay,
you. See you.
thank you. Have a good
Okay.
day.
Same to you. Thanks. Okay, so the recording has been started anyway. I'll probably let me think. What should I do? Maybe I'll deliver the lecture and and upload this recording as I promised to the students. There is just an overlap. An overlap happened when at one at the same time my lecture and some other maybe classes or lectures conducted. I hope that this will be controlled in the dean office or wherever it should be controlled. But our duty is to teach, and that's very good that students are so active and polite to comment. Let me know about this overlap. Just I need a few seconds more to prepare some things, some reports about the overlap, and I'll return to the lecture in few seconds. Good. So I'm back, and let me check that presentation is visible. Yes, it is. Good. Dear students, again, if anyone, I see that some of you are present now. Let me check again. And I appreciate your sharing your time with me. Yeah, thank you. I see the registration. Don't forget to register yourself. You may ask some questions as well. Yeah, no questions. Good. Good. So, first of all, let me introduce myself. My name is Oleksiy Kalmykov. I'm professor of the Department of Internal and Occupational Diseases of Kharkiv National Medical University. And today we have one of topics for our today's lecture about diabetes mellitus in the course of mm, endocrinology, right, for students specialized in dentistry. The diabetes mellitus is by definition an endocrine disease characterized by elevation of glucose concentration in blood, so-called hyperglycemia, and uh, following multiple affections of different systems of organs due to disturbances of metabolism. From point of view of etymology, so the origin of the term, diabein um, in Greek means to pass through, and mellitus in Latin means sweetened with honey. So in total, we have such a context or such a etymological meaning of this term, to pass through sweetened with honey. And it's really clear to what we have in this situation because those patients who suffer from diabetes mellitus due to disturbances of metabolism, they may excrete some quantity of sugar, of glucose with their urinary tract, with urine, if the so-called kidney threshold is uh, over went, right? And while, of course, before this increase of concentration of glucose or hyperglycemia remains inside the organism without direct uh, elimination of sugar of glucose, right? The epidemiology of diabetes mellitus is rather dynamic, and approximately there are about 360 million cases diagnosed annually in the world, with two new cases diagnosed each 7 seconds, and with prevalence of type 2 diabetes mellitus and even rising, increasing much more rapidly than type 1. Annually, in about 80,000 children, the diabetes mellitus type 1 is diagnosed all over the world. And diabetes mellitus is positioned as the fifth leading cause of mortality. About 3 million people die, people with diabetes mellitus die annually, more or less related to diabetes mellitus. About 80% of patients from low and middle income countries suffer from diabetes mellitus. The cause of this is associated with the fact that in low and middle income countries, uh, due to a poor condition of healthcare system, these patients are not diagnosed in time and not treated properly, and therefore the incidence of diabetes mellitus in these regions is relatively higher. Much more often, diabetes mellitus develop in urban population than in rural areas. The rate is 2 to 1. It develops mostly in the age of 40 to 60 years, and only about, not only, but about one-third people are under 60 years old. And about one half of patients which objectively have diabetes mellitus are not diagnosed at all, unfortunately. Again, by different reasons, because the diabetes mellitus has prograded development and course, because there may be not proper conditions, economical or rather in the place where they live in middle and low income countries, because of poor condition of healthcare system and maybe by other reasons. About 500 billion United States dollars are spent annually for healthcare in relation to diabetes mellitus, for diagnosis, for treatment, for prophylaxis, for rehabilitation, and so on. The rating of countries or regions, territories with different incidence of diabetes mellitus is so that the highest rates are in China, India, United States of America, and so on. I must say that these rates correspond to the quality of healthcare system in some aspects, because in many there are that different reasons. For one hand, the higher is the healthcare system, the lower is the incidence because of good prophylaxis. For other hand, better quality of healthcare system make it possible to reveal more patients more properly. So here is the statistics and prevalence of diabetes mellitus in appropriate countries. You may see how different it is. And here is the map of distribution of the quantity of people suffering from diabetes mellitus and the trends of the change of it in different regions. You may see how intensive are the growth in darker regions. You may see that in Africa, for example, about 78% of people with objectively present diabetes are undiagnosed at all. In Europe, there is inclination to higher prevalence of diabetes mellitus type 1 in children. In Middle East and North Africa, 6 of the top 10 countries are in the rating of diabetes mellitus prevalence. In the North America and Caribbean, 1 adult from 10 has diabetes. In South and Central America, about 12% of deaths are associated with diabetes mellitus. In Southeast Asia, almost one-fifth of the world's people with diabetes mellitus is situated in just 7 countries. And finally, in Western Pacific, about 132 million elders have diabetes, the largest number of any region. According to the prevalence trends in association with gender, with sex and age, depending on the age, there are maybe 2 overlaps. In about 20 to 25 years, there are same trends in males and females, and it's about 65 or 60 to 70 years of age, there is again overlap. And the total prevalence of diabetes mellitus in men and women, it has inclination to higher values in men, just at least trends to higher prevalence. So in order to clearly understand the basics and clinical issues of diabetes mellitus in relation to dental practice as well, it's a good idea to have some uh, brush up of basic knowledge in pathophysiology and even normal physiology of a human. The digestion of carbohydrates starts already in the mouth cavity, in oral cavity, and amylase present in the saliva starts to conduct the metabolization of sugar from starch to maltose. And the next significant step in digestion of carbohydrates continues in duodenum and small intestine, where amylase continues to influence on to act on the sugar with transformation into maltose to glucose, with following absorption and distribution with blood to liver and then all over the organism. And this continues in all the intestine, both small and large. The glucose absorption is conducted through the villi in the intestine. Then these metabolites are transduced to the liver, controlled by the hormonal rates or hormonal condition. And then, depending on the demands of the organism, mm, glucose is distributed either for some needs directly and or in depositions. The regulation of the glucose concentration is conducted by different hormones. The most important for us for clinical understanding of the matter is insulin. The insulin secretion is performed in beta cells of pancreas, and its mechanism of action corresponds to um, opening of glucose channels in the cellular membranes. So, in other words, insulin um, influences on the and insulin is secreted in case if there is appropriate level of glucose circulating in blood. This is perceived or can this is a trigger factor for release of insulin by beta cells for one hand, and the action of insulin on different aspects of metabolism uh, corresponds to the following. In terms of carbohydrate metabolism, insulin regulates the glucose transportation into the muscle and adipose cells and other cells. It also conducts the action on glucose conversion to glycogen for storage and breakdown and release of glucose, decrease of it, right? Of breakdown and release of glucose. In terms of protein metabolism, uh, insulin stimulates protein synthesis and inhibits gluconeogenesis, or in other words, use of proteins to uh, produce glucose and energy as a source of energy. And in terms of lipid metabolism, insulin stimulates lipogenesis and inhibits lipolysis. So if you make an overview of these three aspects of actions of insulin on different branches of metabolism, you may conclude that insulin possesses anabolic action. By anabolism, we understand that it's inclined to accumulation of energy, accumulation of resources, right? By decrease of concentration of glucose in blood, which we may register by laboratory tests. The modern classification of diabetes mellitus in terms of etiology is uh, so it includes four types of diabetes. Type 1 diabetes, it is by etiology mostly associated with some immunity mediated, some or maybe idiopathic at all with unknown etiology and known cause. And type 2 diabetes, in which we have mostly problems with receptors to insulin on the cells, and or maybe a relative decrease of the influence of insulin on the cells. The third type of diabetes mellitus is related to some other conditions which result in development of diabetes mellitus. There could be genetic defects of cell function. It may be, or maybe insulin action as well. There could be diseases of pancreas like pancreatitis or some post-operational conditions. They could be endocrinopathies, so development of diabetes mellitus on the background of other endocrine disturbances. This might also happen. Well, then there could be iatrogenic diabetes mellitus related to side effects of medications or chemical-induced diabetes mellitus. Infections, especially viral infections, may also affect the production of insulin and condition of receptors and predispose to development of diabetes mellitus with following development of this disease. There could be also uncommon immune-mediated diabetes mellitus, and other genetic syndromes may be manifested by diabetes. Finally, there is the fourth type of diabetes mellitus named gestational. It develops in pregnant women. So if we generalize the situation about the diabetes mellitus type 1, uh, different genetic, sometimes environmental or immunologic factors leading to destruction of the pancreatic beta cells cause insulin deficiency and with following development of diabetes mellitus type 1. And in the pathogenesis of type 2 diabetes mellitus is significantly different. Primarily, the main role in its development is played by resistance of receptors to insulin in the cells of the human body. And it may be also accompanied by abnormal insulin secretion. And finally, development of type 2 diabetes mellitus. On this slide, there is an illustration of typical or characteristic features of these two types of diabetes mellitus represented. For example, in normal cell, we have average normal quantity of insulin, these yellow ellipses. Then the quantity of insulin and the quality of insulin receptors, quantity of glucose, and um, connection of molecule of insulin to receptor is free and proper, and this leads to getting of glucose inside the cell freely, and everything is okay. While in case of type 1 diabetes mellitus, there is lack, as you can see, there is even no on this illustration, molecules of insulin. And this leads to such a problem that glucose, that these cells are bathing. Yeah, they are placed in such conditions where there are a lot of sugar, a lot of glucose around, but they cannot absorb them without insulin, and there is a lack of insulin. While in case of type 2 diabetes mellitus, the receptors are damaged, they are changed, right? They could be lack of adhesion of these molecules of insulin to these receptors and their action on the channels, and fewer amounts of glucose enter the cell because of this disproportion, right, of requirements of the cell and the quantity and quality of receptors to insulin. The risk factors for type 2 diabetes mellitus include family history, the fact that in this family has been or have been some cases, some people with diabetes mellitus, especially type 2. Mm, it's not so strict as in diabetes mellitus type 1, but anyway, there is inclination. Then, the effect of obesity in the patient with body mass index exceeding 25 kilograms per square meter, and obesity and diabetes mellitus and cholesterolemi and arterial hypertension all together form the metabolic syndrome, so-called metabolic syndrome. And some of researchers, some of doctors even state that diabetes mellitus is just the type 2, of course, type 2 diabetes mellitus is just one of syndromes, one of manifestations of this complex pathologic condition, including, again, arterial hypertension, obesity, um, cholesterolemi, hypercholesterolemi, and diabetes mellitus, right? Diabetes mellitus. Then, habitual physical inactivity. This means that the risk of development of diabetes mellitus type 2 is significantly higher in those uh, whose physical activity, is low. The lower is activity, the higher is the risk. Race and ethnicity. Of course, there is a predisposition, as I have already represented in the on the slides related to epidemiology, that in the Africa region, there is significantly higher risk of development of diabetes mellitus, including type 2 and so on. Gestational diabetes mellitus, or delivery of a baby exceeding 4 kilograms of birth weight, are one of predisposing or associated risk factors with type 2 diabetes mellitus as well. Arterial hypertension, as I have already told, is associated with diabetes mellitus type 2. High density lipoprotein cholesterol level, less than 35 milligrams per deciliter, or 0.9 millimole per liter, and or a triglyceride level exceeding 250 milligrams per deciliter, which is equal to 2.82 millimole per liter. Then history of vascular disease. By vascular disease, we understand mostly coronary artery disease and so on. It corresponds to hypercholesterolemi, development of atherosclerosis, etc. And finally, polycystic ovary syndrome or acanthosis nigricans are also associated risk factors to type 2 diabetes mellitus. In the structure of clinical manifestations, complaints are associated with the so-called 3 Ps: polyuria, polydipsia, and polyphagia. Polyuria is constant thirst. Polyuria is increase of diuresis. Polydipsia is constant thirst, and polyphagia is constant hunger. In total, the main syndromes associated with diabetes include, if we go clockwise on this slide, from side of eyes, it's blurred vision. This blurred vision mostly is associated with or it is caused or mediated by retinopathy. It's because of affection of vessels of eyes and appropriate disturbance of circulation in eyes and following blurred vision. Then, breath disturbances are not specific, while you may perceive smell of acetone from exhaled air. This is because of disturbance of metabolism in patients with diabetes mellitus, and it's a feature of type 1 diabetes mellitus or decompensated type 2 diabetes mellitus. Then, from side of gastrointestinal tract, it's again a feature of type 1 or decompensated type 2 and characterized by nausea, vomiting, abdominal pain, and so on. Some non-specific symptoms, while their presence in a person with diabetes mellitus should be what should give an idea to doctor to check whether there is decompensation of diabetes mellitus. From side of urinary tract, polyuria, glucosuria, and even more, these patients are inclined, they are predisposed to development of inflammatory diseases of urinary tract due to the fact that excretion of glucose with urine forms a good um, structure, a good substance for growth of microbes, microbiota, and development of bacterial infection, or even predisposition to mycosis in urinary tract. Then, from side of respiratory organs in advanced stages on decompensation, in complications of diabetes mellitus, they could be Kussmaul breathing, hyperventilation, and other terminal types of breathing. And from side of systemic condition of the body, typically in diabetes mellitus type 1, there is weight loss. In type 2 diabetes mellitus, there is vice versa, obesity. Then, coming back to nervous system, from side of central nervous system, higher function of it, there is polydipsia, polyphagia, lethargy, and even stupor, especially in case of decompensation of type 1 diabetes mellitus or complications. And a part of what is stated on the slide, patients with diabetes mellitus always suffer from more or less developed changes from side of skin, mucous membranes, oral cavity, and so on. And on some later slides, I'll comment these specific things. First of all, due to the fact that in conditions of diabetes mellitus, main problem is related to disturbance of metabolism, disturbance of energy supply for all the cells with few exceptions, and therefore disturbance of restoration of tissues, cells and tissues. Predisposition to inflammation, predisposition to secondary infections and invasions. So gingivitis or stomatitis and so on, some inflammatory changes from side of oral cavity are typical for such patients, and you should be aware. You might be the first medics, first medical doctors who would reveal diabetes mellitus in these people because they may suffer from stomatological pathology primarily. At least this might be the reason they admit to doctors. They could be secondary mycosis, in this case, candidosis of the tongue, or one more example of candidosis, or trophic ulcer. There is also secondary syndrome of mm, trophic disorders or dystrophic syndrome. Due to, again, the fact that in patients with diabetes mellitus, there are problems with restoration of tissues, uh, these erosions and ulcers and necrosis of tissues are the features of this disease. Parodontitis, inflammatory condition, also might be related to diabetes mellitus. Even loss of teeth, dentina, is an often situation in these patients. So in each of such cases, you should be aware about possible latent or manifested, clearly manifested disturbance related to diabetes mellitus in appropriate patients. Just a few seconds. Let me make a screenshots. Good. Okay. Before we continue with the complications of diabetes mellitus, let me make a short break and then we continue. Just a few minutes for break, not more than 10. If you have any questions, please feel free to ask me now. And now let me look through the registration. Yeah, I see there are 7 of you already registered. Everything is okay. No questions. No questions. Nothing. Good. Okay. Okay. Just a few seconds. A few minutes. Okay, let's continue. The complications of diabetes mellitus are classified into three main groups: microvascular, macrovascular, and others. Microvascular, small vessels, right? These type of complications correspond to retinopathy, disturbances in eyes, neuropathy, changes in nervous system, nephropathy, changes in kidneys. Macrovascular are related to coronary artery disease, to peripheral arterial disease, to cerebrovascular disease. And other types of complications include gastrointestinal changes, genitourinary, dermatologic, infectious, changes in lens, in tissue, pardon, in pressure of eyes, in eyes, intraoral pressure, and periodontal disease as well, for instance, and so on. Few words about microvascular and related to eye diseases, right? It's cataract, retinopathy, different types of it, glaucoma, etc. Background retinopathy. We observe microaneurysms, small aneurysms, scattered exudates, hemorrhages, flame-shaped dot and blot, cotton wool spots less than 5, venous dilatations, etc. In pre-proliferative stage of retinopathy in diabetic patient, there is a rapid increase in the amount of microaneurysms, multiple hemorrhages, cotton wool spots more than 5, and venous bleeding and looping and multiplication and so on. In proliferative stage of retinopathy, in more advanced, there are new vessels on disc elsewhere. There are fibrous proliferation on disc and any other locations, hemorrhages, preretinal, vitreous, etc. And at advanced eye diseases, in retinal detachment or with or without retinal tears, rubeosis, irides, neovascular glaucoma, and so on. There is also a type of changes in eyes as maculopathy, with macular edema, focal or diffuse, with ischemic maculopathy. Other type of microvascular complications of diabetes mellitus are different types of neuropathy. There are sensory motor, autonomic, mononeuropathy, proximal motor neuropathy. In sensory motor neuropathy, we observe from clinical point of view symptoms of numbness, paresthesias, allodynia, and or pain. They could be mostly located. These changes are mostly located on feet and on feet, and sensory polyneuropathy is more frequent comparing with other types. The complications of this condition, of this sensory motor neuropathy, is ulceration, trophic disorders, right? Neuropathic edema, Charcot arthropathy, callosities, etc. Here is on the slide there is ulceration. It's usually painless because of disturbances of nervous system, of sensor disorders. There could be painless ulcerations on the lower extremities and neuropathic edema. Here is the Charcot and arthropathy, trophic disorders of bones and joints, and finally callosities. You may see how intensive they are. Uh, Symptomatic autonomic neuropathy might be manifested by postural hypotension when we ask patient to get up, and in this condition detects decrease of blood pressure, even up to collapse condition. Gastroparesis with disturbances of of uh, nutrition, right? Of the process of digestion, and so on. Diabetic diarrhea. These patients in general are inclined to uh, disturbances of gastrointestinal tract, but because of malabsorption and maldigesty, disturbance of digestion, right, and absorption, there is the increase of elimination of intestine contents takes place. The so-called neuropathic bladder, disturbance of the bladder, urinary bladder tone and function, and so on. Erectile dysfunction uh, due to these changes in mm, both nervous system and vasculation. It's there are problems with erection. Then neuropathic edema. It's manifested by edematous condition of tissues, mediated by disturbances of both circulation and innervation of these areas. Charcot arthropathy, we already mentioned with you, and there was a X-ray on this slide, that there is trophic disorders of joints, gustatory sweating, such as smell from these people, specific smell appears. They may not perceive it by themselves because of adaptation, while other people might do. Then, motor neuropathies. It depends, of course, on what exact nerve is affected. Uh, the most common affection is of cranial nerves, uh, 4, 6, 7s. Sometimes there is truncal neuropathy, rarely. Um, there is also an entrapment neuropathies, such as carpal tunnel syndrome. It's a neuropathy of median nerve, ulnar compression syndrome, myalgia paresthetica, popliteal nerve compression with drop foot symptom, etc. The neuropathies might also be manifested by amyotrophy. It's most common proximal neuropathy and mostly affects the quadriceps muscles with weakness and atrophy. The synonym of this condition is diabetic femoral radicular neuropathy. The thoracoabdominal radiculopathy might also be manifested, and you can see on the slide, there are dystrophic changes and prolongation. Pseudomotor dysautonomia, you may see how these changes on the face, and especially US stomatologists and dentists, might be related to this. The nephropathy is related to glomerular changes, vascular changes. It's one of most common cause of end-stage renal failure in patients with diabetes mellitus and in general, for instance, as well. It develops in 20 to 30% of diabetic patients. The higher prevalence is in Black Americans. The stages of nephropathy in this case is same as you have studied for renal failure at your previous parts of in the course of internal medicine. And we associate the stages with the glomerular filtration rate and morphological condition of kidneys and excretion of metabolites as well, such as, for example, stage 1 is characterized by increase of glomerular filtration rate and kidneys hypertrophy. On second stage, albumin excretion becomes decreased, less than 30 milligrams of albumins per day and 24 hours. At third stage, vice versa, we have microalbuminuria, 30 to 300 milligrams per day. On fourth stage, or overt nephropathy, the albuminuria is exceeding 300 milligrams per day and positive dipstick. And fifth stage, we have increase in blood urine creatinine levels, hyperkalemia, and fluid overload of the body. Depending on the duration of diabetes, the glomerular filtration rate and appropriate kidneys function, proteinuria have appropriate uh, trends. The macrovascular complications of diabetes mellitus are associated with the following aspects. They are 2 to 6 times higher, have higher risk in patients with diabetes mellitus. The major cardiovascular risk factors in diabetes patients are enhanced. There is poorer prognosis once clinical macrovascular disease develops, and loss of female hormones protective effect is characteristic. The coronary artery disease morbidity and mortality in diabetes mellitus type 2, according to Framingham data, research study, yeah, and multiple risk factor intervention trial so they are morbidity and mortality are high and represented on this slide. The infections may be also common in patients with diabetes mellitus because their immunity is altered and they have predisposition to infections, and many typical specific infections develop in them, and they're characterized by increased severity, development of multiple complications, and advanced stages, severity of development. And improving the glycemia level improves the immune function and therefore improves the condition of these patients. So without this, just ordinary treatments of these infections without compensation of diabetes mellitus might not result in success. In the majority of cases, these patients with diabetes mellitus suffer from community-acquired pneumonia, necrotizing fasciitis, acute bacterial cystitis, invasive otitis, external otitis, and so on. Rhinocerebral mucormycosis, because of this predisposition, there is progressive development of secondary infections and invasions in such people. The final diagnosis of diabetes mellitus is carried out on the basis of presence of signs, of symptoms, and there could be three options: either symptoms presence and random glycemia exceeding 11.1 millimole per liter. The random means that without any regard to time since the last meal, or better, fasting glycemia exceeding 7 millimole per liter. If more strictly, it's not exactly 7, but it's the norm varies from 5.5 to 6.6 millimole per liter, depending on the type of test and methodics of test used to detect the glycemia. Fasting means that there is no caloric intake for at least 8 hours, or on basing on the result of glucose tolerance test, the 2-hour glycemia 11.1 millimole per liter and more. The glucose tolerance test is the uptake of 75 grams of anhydrous glucose dissolved in a cup of water, and there is initial evaluation of glycemia in 1 hour and then in 2 hours. Again, in 2 hours, glycemia should be less than 11.1 millimole per liter, and in patients with diabetes mellitus or decreased tolerance to glucose, it is exceeding. The diagnosis is conducted based on standard laboratory evaluation and screening for diabetes mellitus associated conditions such as microalbuminuria, dyslipidemia, thyroid dysfunction, and screening for angiopathy. So we should include evaluation of albumins in urine in order to define the severity of diabetes mellitus and its presence. Then lipidemia and thyroid hormones in blood. Angiopathy. A screening for angiopathy is performed both on physical examination and by additional investigations, such as, for example, X-ray for arthropathy, such as ultrasound for soft tissues changes, visual evaluation, of course. They could be also electron neuromyography to detect the conduction problems, generation and conduction problems in nervous system, etc. And we also have to distinguish types of diabetes mellitus. This distinguishing is performed by serum insulin rate, by C-peptide, islet cell antibodies, and so on. And screening includes, we already discussed with you what exactly. Screening for eye disease is its visual acuity connected with pinhole lenses, and more detailed, thorough eye examination. Screening for nephropathy includes these tests of urine tests. Then screening for nephropathy, detection of albuminuria with appropriate variants. Here is the example of how we can perform the screening for neuropathy, evaluation of sensitivity as well, different types of it, tactile, pain, and so on. The rest of materials are available in my presentation. You are welcome to get it by the link. Again, I positioned here. So I will include it in the, let me find. I will put the link to let me see, just one moment again. I will add the link to all additional materials to this post in my blog. Just one moment. Let me edit post, and just I will make available it for you. Make available this presentation for you. Anyone can view. Apply, copy. Okay, and presentation. Okay, presentation. Here it is. I will transform it into the link. Into the link. Yeah, it's okay now. Presentation. Maybe I will add some more update. So feel free to. Maybe I will YouTube. I'll add it here after finish the recording. So if you have any questions, feel free to ask me. Okay. Thank you for coming. Good. I will make a screenshot. So don't forget again to register yourself. I will repeat this link for you. If anyone comes. And here I have 1, 2, 8, 7 students registered. Okay. See you. Good luck. Keep healthy.